Welcome to the Vapotherm Roundtable discussion today. My name is Jeannie Pedanici. I'm the clinical nurse educator in the medical education division here at Vapotherm. I've been a nurse for 30 years. I have primarily experience in the pediatric emergency department, and my experience with Hi-VNI Technology is in the PEDS-ED. I would like to introduce our guests, Rose Dennis and Diana Maynard, who are respiratory therapists and authors of a recently published randomized clinical trial, high-velocity nasal insufflation in the treatment of respiratory failure. So it's a pleasure to have an opportunity to discuss your experience as participants in this study and as well as your clinical experience using Hi-VNI technology. So welcome, Rose. Can you please give us a little bit of background on experience?
Hi, I'm Rose, and I have 34 years of experience in respiratory care and 21 years of experience in nursing. I've done therapy and nursing in almost every arena. I've worked with high-flow therapy in the neonatal population at the beginning of high-flow, and pretty much using high-flow therapy in all areas right now, pediatrics, adult, and the ER. And we're very happy to be a part of this successful study.
Thank you for allowing me the opportunity to be here. My name is Diana Maynard. I've worked in respiratory for almost 20 years. Like Rose and her institution, we've been using high-flow therapy for several years now. I've had the opportunity to work with it in the NICU, in pediatrics, and in the adult populations. I've used it in the rehab hospital, acute care hospital, and our critical care and ED. So I would say I have quite a bit of experience using high-flow therapy or Hi-VNI in all settings and with all age populations.
Thank you and welcome. We certainly have a lot of experience and expertise today for this discussion. So you see Hi-VNI as a easy tool to set up and manage for the patient and increase comfort.
Time efficient, I think, for the therapists and nurse.
So a question I frequently get from around the country from clinicians is how to titrate flows. So tell me, what are the current protocols in your hospital for titrating flows for the adult patient with respiratory distress? Where do you recommend starting flows?
We recommend starting flows fairly high if you have a patient in respiratory distress. So to meet that patient's demand or exceed that patient's respiratory demand, we're going to start high, usually about 25 to 35 on the flows. And if you got a patient that's really crashing, we might go straight to 40. And then if we need to titrate down, we will. But we want to quickly meet that patient's demand. We start at 100% on most patients, on our chronic lung patients, COPD patients. We may not start at 100%, but it just depends. I mean, again, I always tell my therapist to evaluate the patient, and it's patient dependent on your therapy, but routinely we start high on the flows, high on the FiO2, and if it's a COPD patient and we're concerned about that, the patient's drive to breathe, then we'll come down on the FiO2 a little bit quicker, because normally our protocol is to maintain a saturation of 92%. So we wean the FiO2 depending on that saturation of 92%. So we wean the FiO2s first and then wean flows later.
And I have to echo that at our facility, we manage it the same way. If they come into the ED and respiratory distress, we're going to start at a high flow to meet their demand. Most of them are hypoxic, and we see that, when they initially present with their O2 saturation. So we set the FiO2, usually it's high. We need it high, and then we titrate quickly, titrate down as quick as we can to maintain a SAT at our facility, 92% or better. If it's a known COPDer with CO2 and they're a CO2 retainer, we will titrate to keep SATs 88 to 92%. So we do wean the FiO2 first, and we wean that as quickly as we can before we begin to wean the flow.
So it sounds like you both start high with your flows and your FiO2, and then you wean it down, titrate based on the patient's response. So how does that differ from your initiation of NIPPV therapy for a similar patient?
Well, in NIPPV, at our facility, the way we practice, we usually start with lower level pressures, inspiratory pressure of 10, expiratory pressure of 5. Then we titrate up to meet the patient's needs. So it's the opposite of Hi-VNI. So you're trying to catch up with the patient's needs. We don't start at high pressure. It's very hard for them to tolerate that pressure at all. So you can't start at a high pressure. I would say 95% of the cases, or they would rip the mask off.
You have to allow them to adjust.
Yes, you have to allow them to adjust.
So I'm curious, does that affect the patient's response to improved respiratory?
I believe it does. I think that's why we see a quicker response with Hi-VNI, because you meet their demand
quicker
initially, rather than titrating up like you do with non-invasive ventilation.
Can you also share any recommendations for specific flow and FiO2 weaning protocols?
When they present, we start them either at a flow 30 to 35, FiO2 usually at 100%. Again, we wean the FiO2 to keep SATs greater than 92%, or if they're a known COPD patient with CO2 retention, we wean to keep SATs greater than 88 to 92%, and we do wean the FiO2 first. Our goal is to get below 60% to prevent O2 toxicity, and then we would wean the flow. We would titrate up if we weren't meeting their demand. We can go all the way up to 40, and you know that by looking at the patient, by measuring the respiratory indices, like the heart rate, respiratory rate, heart rate, O2 sat. Looking at your patient or work of breathing is probably the biggest indicator for me. And if you do get an appropriate therapeutic response, then you're going to maintain that flow till the patient starts to do better. We titrate down between 5 and 10 on the flow. And as long as we're able to meet the patient's demand and work of breathing doesn't start increasing, heart rate doesn't increase, respiratory rate doesn't increase, then we continue to bring the flow down.
We got guidelines for the FiO2 as well, where we give therapists different steps or increments of weaning the FiO2, but also, like Diana said, you really got to look at the patient response. So if your SATs are hanging really high, then you could bring your FiO2 down a little bit quicker. But if it's staying around 92, 93, then you might do a 0.1, increments. Slowly bringing the FiO2 down. But we would bring that FiO2 down quicker on patients in the flow.
Right, and I think as you get the CO2 washout effect, and you start bringing CO2 levels down, you're able to wean the FiO2 quicker because you're flushing. You no longer have anatomical dead space. It's all oxygen enriched, your upper airway. And so you can bring that FiO2 down quicker.
Great, so you really
as long as your flow is appropriate.
So always looking at your patient and really using that as your evaluation tool to determine your weaning. So optimizing patient throughput through the ED is very important and critical. Do you have protocols in your hospital for determining disposition for patients among the two different therapies? Is there any differences in your dispositions?
In our institution, if a patient's stable, hemodynamically stable, not requiring drugs that we can't give on the floors, general floors, those patients can be discharged to the floors. And I would say any of our floors, we can put high flow patients. We have Vapotherms on the floors all the time. We wouldn't have enough ICU beds. So if we do have a patient that's pretty unstable, we do have like a step down area that you would see a number of our non-invasive ventilation patients there, as well as our high flow patients. But our patients can go anywhere on the floors.
And it's very similar at our institution as well. I think the more critical the patient is, if you have a patient who we haven't stabilized very well, they're going to go to the critical care unit. I think the patient stabilized better with Hi-VNI. That's why we're able to put them in the step-down unit or even on the general medical floors. With non-invasive ventilation, again, it's that compliance issue. The patient wants to come off, the nurse may take them off. The patient becomes dyspneic. You see work breathing go up, so you put them back on the therapy, non-invasive therapy. So they seem to remain in the ICUs longer because of that reason. and we don't have that problem because you don't have to take the Hi-VNI off of the patient like you do non-invasive. But wouldn't you agree?
Oh, I agree.
Yeah,
and
that's
we
exactly
do have some of them
comes
that,
down to that.
if they're unstable, they will go to the ICU. And if they're patients that we extubate, they didn't tolerate the extubation, we'll put them on high flow.
We do use that a lot.
They may stay in the ICU for a while, but as soon as we get them stable, then we're constantly moving patients to get them out of the ICU.
And the nurses are much more comfortable, like in our step-down unit, we do have non-invasive, but they're so much more comfortable receiving a patient on Hi-VNI as opposed to a patient on non-invasive ventilation. That's a little intimidating to them.
You see the utilization of Hi-VNI as a means to keep your patients out of the ICU?
Yes.
What are some of the patient parameters that guide your clinical recommendations for use of either Hi-VNI therapy or NIPPV?
I would say over the last 15 years, we have been using HIFO from the 2000I in the NICU, and we didn't have the opportunity to use it in adult care. So now we use it in pediatrics, we use it in adult care, and we were not using it in the ED. So when those patients presented in the ED, we would go right to non-invasive ventilation with mask and to try and prevent an intubation. So now I feel we've come full circle because we can use it in every entity of our hospital now. So that's been a plus for us, and there's not really, therapists have gotten so used to it now, and our physicians are pretty much on board that unless somebody's new coming through the door, we don't really have to say, are you okay with me doing this?
Same experience for me and in our facility. Prior to the study, we didn't use high flow therapy in the ED at all. I mean, it wasn't an option. It wasn't a tool in our tool chest. We used it in the critical care areas. We used it in NICU. We used it in pediatrics. But we just didn't use it in ED. I'm not sure why we didn't think to ever use it in ED, but we didn't. And as a result of the trial, I mean, Hi-VNI is the go-to for a patient that walks through in respiratory distress. We're going to try that before we try non-invasive.
And what types of patients are you using it on?
Chronic lung patients, COPD patients, or heart patients, congestive heart failure patients.
Any patient that walks through in
respiratory
respiratory distress is going to
yeah.
go.
A real
Shortness
diverse
of breath,
population.
Mm-hmm.
So adults, if they come in respiratory distress,
Yeah.
that's what we're going to put them on in our facility. In pediatrics, it's great for bronchiolitis because it helps with secretion mobilization. It humidifies the secretions, so we get good clearance of the secretions. So we use it in pediatrics for bronchiolitis. We use it in our rehab hospital as well for secretion clearance and to humidify the the lower airway for pulmonary toiletry. So not just respiratory distress, but for pulmonary toiletry as well. And then, of course, for respiratory issues, distress, work of breathing in the NICU. We use it.
And I think we just didn't see it as an emergency
Just
intervention in the ED. But now when you go in our ED where we have our ventilator sitting, we have the Vapotherm sitting, and
it's because we did not understand or know that we could use Hi-VNI for hypercapnic failure. We didn't know we could increase CO2 elimination by washing out the dead space. So we knew that. We knew if you washed out the dead space, you would get minimal CO2, a decrease in your CO2 levels. But it was not just minimal. It was just as effective as non-invasive ventilation in bringing down the CO2 levels. And we didn't know that prior to the study. Right. So patients that come in respiratory distress, the majority of them in the ED are going to have or going to be hypercapnic, not just hypoxemic. So it just never clicked to use Hi-VNI because we didn't understand the technology, first of all, and we didn't know what Hi-VNI was capable of.
And in the ICU we were using it, but again, patients hypoxemic respiratory rates were up, they were working hard, and it would meet that need. But again, we just didn't think about it.
And if they were hypercapnic, we automatically went to non-invasive. You didn't even think this because this was for Hi-VNI, we thought, or high flow therapy was for hypoxemic failure.
So you definitely see it as an effective alternative to NIPPV. Can you share a situation when you, in a clinical situation where you recommended Hi-VNI instead of NIPPV?
I would recommend it, and I think it should be the go-to therapy for all patients that present with respiratory distress if they're dyspneic and respiratory failure. Non-invasive ventilation is an option, but I think in most cases we should start with Hi-VNI. The patients will tolerate it better. They can still speak to you. They can still eat if they, as they get better and need to eat, they can still take things in orally. You don't have to troubleshoot Hi-VNI like non-invasive, and it's effective therapy for CO2 elimination.
And I just had one last week, so I'm just thinking, but I had one patient last week, heard the therapist in the hall talking about this patient struggling, and the patient wasn't tolerating the mask with non-invasive ventilation, and so I said, well, did you try high flow? Did you try the Vapotherm? And so that therapist and my lead therapist went back to the bedside and actually put that patient on high flow with Vapotherm, and the patient did fine with it. So, I mean, I think we get those all the time.
I do
Sometimes
too.
you just don't think about it.
That's a great
And it is so
Yeah.
common that you're not thinking about
Right,
it.
right.
So it sounds like you do have some autonomy to be able to advocate for your patient and really know what's best
Yes.
therapy.
Yeah, we do have that. I think that alternative now is like before, if you're really just trying to prevent the intubation and a patient didn't tolerate the mask or non-invasive ventilation, again, because of leak compensation and pressure of that, air in their face and claustrophobia, high risk for aspiration, then we didn't really have an alternative, but now we do. So again, the therapists, they are really used to thinking about that now. So when you get together as a group and you think, brainstorm together, let's try that. It usually works.
And it's really exciting for me to be a part of and watch the journey of Hi-VNI. From when it was first presented, when we first started using it, it was an option for hypoxemia. And then as we learned that we could use it in the treatment of hypercapnia, to see the physicians, not just the ED physicians, but the hospitalists and the pulmonary physicians slowly begin to use it to now where we are is we use Hi-VNI before we'll use NIV. It's been neat to watch that transition over the last couple of years.
And I would say
watch them begin believing in it.
Yeah. One other example we see in the hospital, because we have a hospice floor, and we would have patients on high flow, and trying to get that patient off of high flow onto the hospice floor never sort of happens. It rarely happens. So usually when that patient moves from a general floor or palliative care to hospice, the Vapotherm goes with them. And because the patient or the patient family still wants it, we pretty much leave it as a patient comfort. They can have it until that time comes, and then we'll take it. But we see it in that population of patients a lot.
We'd have patients, in the COPD population, you have your frequent flyers, and they come in, often. We all, the therapists and the nurses, all know those patients. They're like family. So we'd have one of our frequent flyers come in through the ED and be randomized to Hi-VNI. And I like it so much that the next time they came in, they specifically asked for, remember that thing you put on me last time?
We've had that.
The cannula. I want that. Don't put me back on that mask.
Yeah.
Don't put me back on that mask. I mean, we literally had people requesting it.
Yeah.
COPDers requesting Hi-VNI when they came into the ED.
Sounds like a big patient satisfier.
Oh, yeah.
Definitely.
Although our focus as clinicians lies with clinical benefit and the patient outcomes, similar to what you've been describing, the economic impact of the therapy interventions, we can't overlook that component as well. How does Hi-VNI impact the economics in your department?
What I see, I think it impacts length of stay. I think it helps reduces stay in the ICU, stay in our ER as well. Sometimes getting patients stable quicker. A few that can discharge from the ED or go up to our OBS floor. But certainly patients feel more comfortable on it and go to our general floors a little bit quicker because of it and not take up an ICU bed.
I agree. And in addition to that, I think just the time involved in administering and troubleshooting and adjusting the therapy for the clinician is much less time involved. So I think you save money there as well. the therapist can go do other things.
So on the front end, it may cost more in consumables, but we think cost avoidance and
Right.
a decrease in expenses when it comes to labor and for the nurses as well as the therapists. The time it takes to care for these patients, and if you got a therapist who's going to be called 5-6 times, can you take this patient off so they can eat off of a mask? Can you take the patient off so they can go to the bathroom, so they can take medication? So there's a lot less of that now. So a therapist, I'll tell you, they can tell you that story, that it's so much easier to manage a patient with a cannula on versus a mask.
So a lot less interruptions for the clinician.
Especially those unstable patients. If it's a stable patient, just an OSA at night, sleeping, who knows how to manage their machine, not a problem. But those critical patients you're trying to get stable, they can require a lot of therapist and nurse time.
Right.
Yes, more than the ventilator patients.
Right.
That's what we see.
Absolutely.
Yeah.
Absolutely.
Sounds like it positively impacts productivity for your departments as well. Can you talk about what was important for your team in terms of clinical protocols and training to successfully integrate a new technology like Hi-VNI into daily use?
Well, what we saw was sort of getting everybody on board. That's our therapists, the physicians, our medical director, the nurses, just informing and educating everybody on what we were doing and making sure they understood the therapy, and then actually seeing the results, I think, made the difference.
And seeing the results did make the difference.
Yeah. So
I
just
think
telling them.
that educational foundation is very important. I think it's very important that the clinicians, from the physician to the respiratory therapist, that they understand the technology. I think there's probably misconception about how it works. I think resistance some facilities may have in using Hi-VNI therapy that is specific to Vapotherm. The resistance they may experience with their physicians, I think it's due to a lack of knowledge of how the technology works, because again, it's not just high flow therapy, bulk therapy. It's high velocity therapy that is able to do such an effective job of washing out dead space.
And what we offered our staff as well is support. 24/7. So as we were doing the study, if they had questions, they could call. We had somebody on call. They could call, even if the person needed to come in. So I think that's why we were pretty successful with our study. Made sure everything was done the same way, because we had that support and we had the protocols pretty much readily available.
And then, as you said, Rose, as soon as the clinicians saw the results, because it didn't take long at all.
It did.
Once they saw the results, they bought in. It was exciting.
Yeah.
As a respiratory therapist at our facility, we have the privilege of autonomy. I know many facilities, the respiratory therapists don't, or they have very little, but in our facility, we do. And I think this allowed us to have even more autonomy in the treatment of patients. When we go to the physician, we talk to him and recommend therapy that he may reluctantly let us go ahead and try, and he sees that it works. It gives us credit as to what we're doing and what we know. And I think Hi-VNI therapy has provided us with even more justification for autonomy in our facility.
I think for us initially, getting the physicians aware of what we wanted to do in the ED with high flow. They didn't really realize we had Vapotherm throughout the house for some reason. And we were treating patients and having success with these patients' outcomes. So in the ED, once we sort of got that information to them, this is not new technology for us. We've been doing this 15 years. Our patients are safe, because we had some doctors who felt we were bringing new therapy in the house, and thought respiratory wouldn't know what to do with it. We knew what to do with it. So once they realized that, again, we were put in the driver's seat. And normally that's what they let us do. We have protocols, and we do drive the car. And we sort of see these patients, put them on what we think would work. And again, we know we have choices too. We have them to consult with, and we do have other choices. So if high flow doesn't work, we could try non-invasive ventilation as well. So it's not like, just one therapy that we would have. But again, it worked very well for us, because we did have the knowledge and experience already, and the doctors really trusted what we were doing with the therapy.
And it fits, for us at our facility, it fits right in perfectly with our protocols. It really does, because we do have an oxygen pathway or a protocol. It just fits right in with that one. We don't have to call to get an order for Vapotherm or for high flow therapy. It works in our ventilation protocols. It works it's an option for our secretion mobilization protocols. So it just fit right in seamlessly in our protocols.
So having those evidence-based protocols really supports the autonomy of the RTs and really makes a difference in for the clinical decision making.
And it allows us to practice to our potential and actually assist the physician, free him up so he's not, and so he has more time to focus on other patients.
We just get parameters and pretty much up and down how we need to take care of the patient.
What are the assessment parameters you use to guide your clinical decision making in moving a patient from Hi-VNI technology or NIPPV to a higher level of care?
We look at the patient's response, so their work of breathing. We can tell fairly quickly whether or not we're relieving the patient's work of breathing just by looking at them. So are they using their still using their accessory muscles? Is their heart rate still climbing? Is the respiratory rate still climbing? We assess whether or not there's an appropriate response by those respiratory indices. And also, we can see if the patient's not responding, if the therapy is failing by those indices. Usually, we don't have a time parameter. We don't assess every 15 minutes. When those patients come in respiratory distress, we place them on the therapy of choice, whether we've chosen Hi-VNI or non-invasive ventilation. But you should start seeing a therapeutic response fairly quick in either case. A lot of times in non-invasive, the patient's fighting. They're non-compliant. They're not very compliant. They're not able to be. And it's not going to work. Traditionally, those are the patients we would just go ahead and intubate. But we don't just rely on blood gases to see if it's working. I mean, you can tell a lot about whether or not the therapy's working by the patient's work of breathing.
We look at altered mental status, patients becoming unresponsive for some reason. Then those patients we would certainly take off of high flow or non-invasive ventilation and intubate.
Yes, I agree. So they're becoming more respiratory depression is increasing. Right. Then you would escalate the therapy.
You need the spontaneous.
So there's
respirations.
It's hard to give you a time. Yeah, because
it's hard to get time.
Yeah, if we're seeing improvements in respiratory rate and then the SATs, sometimes SATs may take a little bit longer. But it's a holistic thing. Cardiac arrhythmias or something that we think is life-threatening, then we're going to make a move quickly.
So you definitely want to see that response in the heart rate, respiratory rate,
yes,
work of breathing, and your blood gas improvement.
Yeah.
As you were implementing the new technology with the Hi-VNI therapy, what were some of the challenges that you faced during that implementation?
I think some of the challenges was understanding the technology. So some of the things that we did see, or one of the things that we saw, was that the physician would order the therapy with flows that were too low. You have to meet the patient's inspiratory demand, and they would order flow of 10 or flow of 15, which for a patient in respiratory distress, their demand is greater than 20 usually, an adult patient anyway. So ordering the flows too low, we've experienced that a few times, but education, that's how you address that, is with the education. And I think another problem that, another challenge that we have is the bulkiness during transport, the heaviness during transport. I know Vapotherm has come out with a lighter battery, but we haven't purchased one yet, and we're budgeting one for next year. But I think the heaviness of the unit during transport has also been a challenge, and to make sure your therapist doesn't switch the patient to a non-rebreather for transport, and that we keep them on the same level of care, like same level of therapy for that transport, even though it might be a little bit slower. And so that's kind of been an obstacle.
I think what we saw was probably mainly physician driven in the ED, where the physician still wasn't thinking high velocity therapy, but because they were used to and had seen outcomes with non-invasive ventilation, then we would get physicians just wanting it regardless of what we were telling them. again, you have certain doctors rotating in your ED. So if it wasn't the physicians who was involved with the studies, we would have to then explain again how it works. Let us try this. And we got a few, when we randomized patients, that would say, no, I think I want non-invasive ventilation anyway. So we really had to show those doctors that the therapy worked. And it was just as good. It was a good tool for us to use. So that was some of what we saw. And then getting all the therapists on board in the ED, because we had to change some of their mindset too. And them being the more aggressive person or clinician at the bedside to help teach the nurses, help teach the physicians. So that was some of what we saw. And then after we got our therapists not being so shy about it, and just to think, well, you use this on the floors, it's not so much different. But you have to meet that patient's demand and not start with the flow so low. Don't be afraid, and you can always titrate down. So we had to really get therapists to see that 40 wasn't bad, 35 is not bad, because they wanted to start low and then go up.
You're exactly
they thought more like non-invasive
yes,
ventilation.
That's exactly right.
Yeah, so we really had to get that
agree.
switched around. Yeah, thought process.
Different initiation process for the different therapies. So education was important, making sure everybody understood the mechanism of actions, and it sounds like the RTs really can drive that understanding to the rest of the clinical team.
So and a lot of them gave in sometimes with the physician. They really, the doctor wants this. So unless one of us came out of the office to go talk with the doctor, which we did, they would give in.
And now you're seeing more autonomy with the therapists?
Oh, for sure. Yeah, they're comfortable with it.
Is there anything specific that you had to really hone in on to get the physicians to really understand and believe in the therapy?
We had to pretty much let the physicians see the results quickly. I'd get the results right to the bedside so the physicians could see, or they could just come in and see the patients themselves. And once they saw it pretty much in action, then the proof was sort of in the pudding. My patient's doing better. I think this can work. I see the blood gas. I see the patient's CO2s coming down.
They look much more
Parameters are looking much better. Hemodynamically, they're okay. So I think they
bought
really
into it as soon as they began seeing the results.
Yes.
We did have a few physicians that rotate through. They might not always be in the ED, that aren't aware of the therapy. During the trial, we'd go to them. They happen to be the treating physician, and they would not want to put the patient on Hi-VNI when they randomized to Hi-VNI. But we had a lot of support from our medical director over the ED, so he would address those issues immediately and educate that physician. So even though as a therapist, being part of the clinical trial, you try to educate that physician who has rotated through your ER, but they don't know who you are. They're not sure. So sometimes you would struggle. I would struggle in getting that message across. But I could go to my medical director, and immediately he would help me diplomatically handle that situation. So that was a great support.
Week after week, it got easier. You got more doctors on board because we had a physician champion to that.
Yes,
was really there,
which makes a huge difference. And then another challenge. It wasn't such a big challenge, but it was a challenge, especially initially. Was our ED physicians were on board with this. They're ordering it, but as the patient transitioned to an inpatient, the pulmonary doctors would come by, see the patient's CO2 level was elevated, although he obviously wasn't following the multiple blood gases, but he would just see an elevated CO2 and immediately DC that Vapotherm and put them on non-invasive. So making sure we immediately saw we had to get to our pulmonary doctors and get them and educate them, or they would be pulling all of our patients out of the study.
We saw the same thing.
But as soon as that education was done, in fact, we should have educated them beforehand. We kind of mentioned it. We kind of did, but they have so much going on. I didn't, when it actually started happening.
I think they had the same mindset we had.
Yeah, they did.
High flow was useful.
They did. I even had them tell me that initially when we started this.
Right.
When she educated them, and then they began to see it, they backed off that.
What are your recommendations for a hospital that's not currently using Hi-VNI technology in their adult population? How would you recommend that this therapy be implemented?
I would suggest this because over the years of using high velocity therapy, we have been like a resource to hospitals that were hesitant or just weren't sure about the therapy, how it would work. And we don't mind doing that now if there's hospitals that want to send a therapist or want to call us or sort of see what we're doing or how we're doing it. I think that helps sometimes for those hospitals who are just not sure if they're going to get the patient outcomes or aren't sure the therapy works. We could certainly share real cases with them. I think that would help those people who are just not sure.
Yes,
You know?
I agree with
I think
you.
the evidence is there. And
The
I think,
evidence is there.
yeah. You
They
can
want
give
that
them,
validation.
You can give them
Yeah.
articles. You can give them. Because sometimes people think, well, you guys did the study. You guys gave us the information, and all you gave us was the positive, none of the negatives. But I think if you find a facility that's using your technology and have that person reach out to them,
We
and
don't
it
have
works.
a dog in
Right,
a fight.
exactly.
with
So we are willing to share, and I think that might help some of them. They could certainly come visit, put hands on, look at it, see what our patients look like with it on, and that's my suggestion. I don't know.
And I think the proof is in the pudding with Hi-VNI. The evidence is there. They're just going to have to practice evidence-based medicine, and they can.
They can
like
call
you said,
first.
call for validation.
They can call or again, site visit. I think we all sort of share these days. So I mean, I think that would be good if, just like us going to a new EMR, I'm going to go look at it, so I can get a true feel for it. You can tell me this all day long, I might not really know exactly what it's going to be like until I really see it. So it may be that case with a lot of these hospitals that don't know how to move it from neonatal or pediatrics into the adult area. But when we had it just in neonatal and pediatrics, we wanted to get in our adult patients. Yeah, we wanted it. We kept saying, well, when are you guys going to get an adult unit? And so we weren't scared of putting it in our adult areas because we saw how well it was working on our kids,
Change is always a little bit challenging to bring in new therapies.
But I think in facilities that they look to patient safety and outcomes, they have to at least consider it. I can't imagine them not at least considering it since the evidence is there.
Well
And
said.
we all claim to be evidence-based institutions.
Are there specific patients that you would only use NIPPV instead of Hi-VNI as the preferred therapy?
I would only do that and not evaluate or consider high velocity therapy on a patient that comes in the ED and their therapy at home, or they prefer non-invasive positive pressure ventilation because that's what they're used to. That would be a preference of the patient. I mean, because that's what they're used to and they've responded well to it. That's what they want. On those patients, I probably would leave them on the therapy because it worked.
Somebody that may not have that mask anxiety.
I really can't think of a patient where non-invasive would be preferable just because of the interface.
Exactly.
And the struggle you have getting the patient to relax. And
Because you have some patients who just want what they want. Some COPD patients, they want what they want. So if they're used to the mask, and that's what they want. And then, again, those patients, sometimes when they settle down and they want to come off because but they can't really come off of the therapy completely and maintain their SATs, and then we'll put them on high flow as well. So we'll have high flow and non-invasive ventilation sitting in their room as an dual therapy. When you're doing this, you have that on. So I mean, but that's the only time I could think of I wouldn't.
I'd have to agree. I can't think of a time. Patients much more compliant. They both produce the same results. So why wouldn't you use Hi-VNI as opposed to non-invasive? Unless maybe the patient, our COPDers are pretty headstrong. They know how to treat their disease.
And they don't see that this will work.
Other
That
than
cannula is going to work like my mask.
They're not going to
works.
change.
Right. So just like a patient who, if you want to give them an MDI treatment, their medication, but they're used to taking a nebulizer, you can't prove to them that this is just as good or probably better because they're used to that nebulizer.
So sometimes patient preference
Yes, I guess.
play in.
Yeah.
Do you have specific clinical criteria for disposition to the ICU for a patient on Hi-VNI or NIPPV?
It depends on the patient. So the more acute the respiratory distress is, the more needs the patient has, whether or not they're hemodynamically stable, whether or not they have multiple issues going on. There's several factors that influence that, not just respiratory distress and their response to the therapy you're giving them. There's a lot of our patients that come in have multiple comorbidities, and they may be having arrhythmia going on at that time. So, I mean, there's multiple factors that affect disposition.
Their hemodynamic status, their medications, because if we got somebody on pressors or inotropes like cardiac drugs, they can't be given on the floors. They're going to be in the unit. But we can support them with, high flow.
And it comes down to we can support a patient in the ICU all the way down to the rehab hospital on Hi-VNI therapy.
And even some vents on the floor. So just depending on how unstable the patient is, whether they're in the ICU or can go to the floor.
So again, you're kind of looking at that patient's response to the therapy to determine their disposition.
Yes,
and usually it involves other therapies.
Absolutely, right. So there's multiple factors that drive the decision for the disposition.
And the mode of therapy, respiratory support, is not usually what drives that.
Because a therapist can go anywhere. It's just really how critical your patient is.
So unless the patient's intubated. So
that's exactly right. I can operate a ventilator out in the parking lot.
Right. And if it's a chronic patient that's intubated or trach, our floors, we will put a vent on the floor. So, I mean, it really depends on how acute and how unstable that patient is, A lot of other factors.
So what the trial basically showed us that, and helped us to understand is don't be afraid to try it, because you can always cross over to non-invasive ventilation. That's always an option. So don't be afraid. Try it out, because when you try it, you'll see it works in most cases.
I think most clinicians, if you had to choose a mask versus a cannula, I would want a cannula. That's just me.
Yes, and
most patients.
A
lot of patients feel the same.
So you see it improving the patient outcome and the patient preference and comfort.
And the experience, patient experience, which we're all about patient experience.
Right.
Preeminence, healthcare. So.
Because even those hospice patients, when they're suffering, and they feel so much better with that cannula. Absolutely. They really do. Don't be afraid to try new technology. Don't be afraid to change. You need to introduce change, because you could always go back to old therapy and the way you used to do things. But I think if they aren't afraid to try it, they may see some very good patient outcomes.
Outstanding discussion, and thank you both very much for taking time to share your experiences with Hi-VNI Technology, specifically as an effective alternative to NIPPV. You gave us a good understanding of how you use the evidence and your clinical expertise to guide clinical decision making to manage patients in respiratory distress.
Thank you for the opportunity.
Yeah.